So first of all, thank you for this kind introduction and first presentations, and thank you for the organizers for inviting me. It's not my core business, biomarkers, so I'm more of a clinician with some lab history, and therefore I hope I can prove you that although biomarkers have very high potential, that at this time point using them for measuring efficacy of treatment is maybe not yet feasible. I don't have any particular disclosures for this talk. And I want to get you through a little bit of what is a good CSF biomarker for treatment response, what are maybe good candidates, and most important, are the candidates now any good? And the most focus of my talk will go on how to get from a bench to bedside with these kind of biomarkers, and what do we really want to know when using these biomarkers, and is that now feasible with what we have today? Biomarkers, when you use them for assessing treatment response, they should be relatively easy to measure. General lab conditions, not too much reproducibility issues or reliability issues between the labs, not being too sensitive for sample handling, because everybody does it in a different way, the lumbar puncture. It has to be meaningful for the individual patient, because a lot of research has been done on a group level, but we should use it as a single measure in a given patient and then know what to do with him. And it should be quite specific for MS. Relatively stable, not too much influenced by external conditions like how much did I smoke, or how much alcohol did I use, or did I hit my head in the last week, or yes or no. Fluid intakes, like you know, with brain atrophy measurements by MRI. And it has to be kind of a good representative for the whole disease process, not only neuroinflammation, but also neurodegeneration or remyelination process. A lot of things are going on, and we need to know what we are measuring. First, I want to make a big respect for the people that are doing that research, because it's not easy. There are guidelines of, and the Biomarker European group, for example, is a network that tries to get CSF biomarker research to a higher level, and they produced guidelines on standardization and collection and biobanking. And it's not easy, because I don't want you to get through these things, but just appreciate how many things you have to take into account to just have a good sample and have it stored in a good way. Another thing is that when using biomarkers, you have to use the good controls, and there is also, from the same consensus network group, a kind of consensus on how to use controls, yes or no. And when you look at definitions for therapeutic marker, they say, okay, patients can be their own control in follow-up studies. So you have to have repeated lumbar punctures in these studies to know what you're looking at. And so they anticipate a higher dropout rate than because you have to repeat a lumbar puncture in a study of biomarkers. What are good candidates? And Professor Friedman has already shown us that there are a lot of processes going on. You can measure antibodies, you can measure cytokines, biomarkers that show damage, adhesion molecules, MRI, DNA. These kind of things are all representative of the process, and there's a number that you can pick up in the CSF. And which are, there is a good review here, below you can see the reference, but I just and it's a review on all kinds of biomarkers for all different reasons, prognostic, diagnostic. So I took out only the ones that had shown treatment effects. And there's a lot of biomarkers, but you see that only a few of them have done some studies on treatment efficiency. And I took them out and I listed them for you. Here are some antibodies, here are some cytokines and chemokines, damage or repair molecules, damage molecule, neurofilament light, for example, chitinase 3 are others, and chemokines are very popular. And only these 3 in red here have been shown a treatment effect on more than one treatment, because the other ones were only researched on response to one treatment, being interferon or natalizumab or fingolimod, while these have more on that. So are they any good? Are they specific? Are they differentiating between treated and non-treated? Let's go into that. And I'm happy to show the same publication that Professor Rod did in his talk, because oligoclonal pans are maybe the oldest biomarker of diagnosis, and can we use it as a measurement? Well, we see that natalizumab, it's well known that it has some effect on B cells. So in this patient you see oligoclonal pans disappearing, in this one you see it changing. But what they state is that they found no difference in intrathecal IgG synthesis or the oligoclonal changes when they looked full responders compared to patients with clinical relapses or MRI disease activity. So even in these patients that is on a oligoclonal band were changing, this patient might have had clinical relapses or MRI activity, and then it's not a good measure of having a good treatment response. Another one is autologous hematopoietic transplantation. We all see that as a very, very efficient treatment, although in patients, even at 4 years and 6 years at follow-up with repeated lumbar puncture, you don't see oligoclonal bands changing. So maybe that's not a good way of seeing treatment effect and knowing that, okay, this patient might be asymptomatic, is he doing well, yes or no? So another candidate, neurofilament light, and I agree, it's a very potential good candidate. Here, a study that looked at pre and post natalizumab, 1 year before and a year after. This is neurofilament total and neurofilament light, and you see it going down. It's what my previous Professor Rod also showed, that it has some effect. And also the same group with the same first author did the same research on fingolimod. It was the Freedoms trial, and you see it going down in treated patients with 0.5 milligram, as opposed to placebo, it's going all the way. So this might be a good marker. But then again, it has to differentiate between patients that were treated and not treated. And if they were not treated, you expect these neurofilament lights to be higher constantly, or because we cannot monitor all day or every week with lumbar puncture. This is a study, a multi-biomarker follow-up study of about more than 50 patients, relapsing remitting in CS patients that were followed up and ended there. And there is a difference in patients and with or without disease activity in the ones that were treated, yes or no. So clinically there is an effect. And then here neurofilament levels with the treated cohort at baseline and at follow-up, it goes down very nicely. But this is the CIS or MS untreated cohort at baseline and at follow-up. But you cannot differentiate between them. So the ones that are not treated at follow-up had also a reduction in their neurofilament light, while you might expect them to do disease activity or ongoing neurodegeneration early on in disease. We're losing brain. And neurofilament light here might falsely reassure you. And then there's a question: how specific is that? And neurofilament light is not specific for MS; it's specific for axonal damage. And it's not too bad. It's okay because in MS there is a lot of axonal damage. But if you have other diseases coming in, I don't know how many patients with MS develop frontotemporal dementia, but if they do, there is a good correlation even with serum neurofilament and the amount of atrophy of the frontal lobe. You don't have to be diseased, you just have to box, and if you do boxing as a hobby as an MS patient, you increase your neurofilament light. This is a study not only with neurofilament, also a complete tau or GFAP, but neurofilament. This is before, this is at 6 to 10 weeks after a boxing match, and this is 3 months after, and our neurofilament goes down. And you see the ones in blue here, it doesn't really change, and the ones in blue are probably the guys that won the fight, because these were the ones that didn't got as many hits as the red ones. So if you had a patient that the week before his lumbar puncture had a traffic accident with a whiplash, for example, you might see different measurements of neurofilament light. But how to go from bench to bedside? You want to implement this therapeutic efficacy biomarkers in daily practice. And there is a perceived problem with repetitive lumbar puncture, but I don't want to make a fuss out of it. We should have patients have good experience with lumbar punctures. And standardization of measurement, we could overcome that. But how to incorporate it is in concepts as NIDA, and Professor Friedman showed is that it should help us saying this is a real NIDA patient and this is a NIDA patient that looks doing good but in the end is going bad. And there is a concept of NIDA 3, no clinical and MRI, and do we get cognitive tests in that clinical thing is already a discussion. NIDA 4, normalization of brain volume loss, but there is a problem of individualization of that measurement. You could think of NIDA 5, but because evoked potential changes is a functional outcome, you could put that in there. And then, of course, you could say, okay, NIDA 6 is when there's no abnormal CSF biomarker value. And it would be nice if NIDA 6 here, this biomarker value, could overcome all these other issues. You say, if this is normal, all the other ones will be good because that's a measure. And then the patient probably will be okay to do a measurement. And there is a very nice position in a recent journal, Multiple Sclerosis and Related Disorders, January this year, a French group, they said, well, what we're doing with treatment is getting untreated patients as closely to normal. And for example, with brain atrophy, we almost normalize it. And if you take an individual patient, we get them below the threshold, but it might be that there is a small difference in short term here that doesn't mean much, but this small difference in normalization might be crucial in the long term. And this is what we want to pick up with the biomarkers, saying, okay, this might be nice to incorporate CSF biomarkers in the NIDA, and saying, okay, there have to be inflammatory biomarkers and neurodegenerative biomarkers, and if they both are normal, then patients are doing fine. But there are no studies that look at the long-term correlation of CSF biomarkers and the evolution of disability in the long term. It's logic, biomarkers are coming up now, and we need many years to correlate that. But before we need that, we need to find biomarkers under relapse-free or NIDA 3 conditions in order to say whether it's completely normal or it seems a normal biomarker, but it's not yet a normal biomarker, because this small difference will learn us what we want to know. Is this patient doing good when his MRI is normal, when he has no clinical disease activity? Yes or no? So now we don't know that if the current proposed CSF therapeutic biomarkers are able to monitor this. we see neurofilament light going almost to normal or normalize in patients that are untreated and relapse-free for some time. So we want to know that. So to conclude, I hope to show you that the study of CSF biomarkers is difficult. And I have deep respect for our lab colleagues and at our university also, the colleagues that do this, they have a hard job. And different biomarkers monitor different aspects. And neurofilament light has promising aspects, but it has its limitations. And maybe it would be a good thing to objectify a damage or a relapse. When you know MRI is negative and you have a patient, is the relapse really, or is it pseudo, or is he just complaining because his wife or is having a difficult time and is psychological? Then maybe this might say, okay, there is no damage, so I'm okay. But that doesn't mean that the treatment now is working. So the goal of complete remission of the disease is only measurable when we have biomarkers that say, okay, in terms of NIDA, it's normal. When there is any small disease activity, it's not normal. And that's not yet there, and we need further research. And with that, I thank you for your attention. And this is the place where I work. It's not always as sunny as on this picture in Belgium. Thank you.